Welcome everyone to episode number 3, a special edition of the Disability Filibuster. We are live and, pretty close to being on time, thanks to the awesome mastery of our invisible tech support team of one, Aslan Thomas. So thank you, Aslan, for starting us out. We have a really good group today, both on the screen and facing the screen from your homes. And last heard we were approaching an audience of 100, which is pretty extraordinary, given that we only posted the registration link less than 24 hours ago. So clearly there is much interest. My name is Catherine Frazee. I will be one of your co-hosts today, and my pronouns are she, her. I come to you from Mi'kmaq, the ancestral and unceded lands of the Mi'kmaq people, where I am grateful to live as a peaceful and humble settler. And I appear on your screen, for those of you who would appreciate a visual description, as an older white woman in a high-tech wheelchair, wearing a speckled blue and white sweater, sitting in front of a bookcase, and with a very impressive array of breathing and suction tubes pointed right at my mouth. So I apologize. It's very difficult to read my lips, but hopefully the interpreters and the captioners will do their stellar job and make sure that everybody can follow. I'm also not the main event. So my next pleasure is to introduce my co-host, a long-standing friend and ally and supporter of the filibuster and of the disability rights movement, Dr. Ramona Coelho. Ramona?
Thank you, Catherine. My name is Dr. Ramona Coelho. I go by the pronouns she, her. I am speaking from the traditional Terry of the Attawandaron, Anishinaabeg, Haudenosaunee, and Lunapiwak peoples. I'm sorry for my pronunciation. I'm a family doctor, and I care for people who may find themselves in the margins, people who are vulnerable. From Montreal, where I did home care for people who had advanced dementia, disabilities, or lived with addictions. And here in London, Ontario, where I live now, I take care of also people who find themselves in the margins, so many men out of prison or facing criminal charges, the LGBTQ+ community, as well as most of my patients have a disability, and also refugees. Well, there you go. So that's me. Thank you very much, Catherine.
Thanks, Ramona. And I'm just going to say a few words by way of introducing this session, which really is a special edition of the Disability Filibuster. We're responding in this broadcast to the special Joint Committee on MAID that is happening in Parliament right now. They've had 3 meetings of substance thus far. And as a quick refresher, the committee was struck earlier this month and mandated to conduct a review of MAID in Canada, and I quote, including but not limited to issues relating to mature minors, advance requests, mental illness, the state of palliative care in Canada, and the protection of Canadians with disabilities. So, easy stuff, huh? They are committed to reviewing all of these heavy topics and producing a report that will be tabled in Parliament on June 23rd. Their hearings, I want to point out for those of you who aren't so familiar with this process, they're always streamed live and also archived for viewing anytime on the PearlView website. And maybe someone in the back end can post that link sometime in the chat room for people who don't have it and want to watch the original to which we are, upon which we are elaborating today. It's worth noting that you can easily clip clips of any length from any of these hearings. You don't need any special bandwidth, equipment, or editing skills to produce a clip and share it. So if you actually watch a hearing and see something that impacts you, either because it's brilliant or outrageous, you can capture that clip in the comfort of your home and you can share it or keep it for posterity. So if any of you want to know how to do that and you need some coaching, we have people. So just get in touch with us. Now, many of you have been watching live streams during the committee hearings. You may have seen the disability filibuster live tweets that both Gabrielle and Sonu have been valiantly producing, and they present a brilliant analysis of what is going on before our eyes. If you experienced the meeting on this past Monday, April 25, you will have noticed that there were 8 invited witnesses, all of whom had medical credentials of some form or other. Of the 8, 3 really stood out to us, both because of what they said and because of how they were received. Gabrielle and I were very impressed with what these 3 individuals had to say, but not very impressed with the way in which they were rushed, undermined, and frankly interrogated. So we thought, let's invite them to the filibuster. Let's make sure that the critical perspectives that these people bring to the conversation are heard and fairly heard. 2 of those incredible witnesses are here today, along with a few filibuster faithfuls who you will recognize from our last broadcast. I think it's going to be a really groundbreaking and significant conversation. So get comfortable and welcome to the Disability Filibuster Special Edition. Back over to you, Ramona.
Thank you, Catherine. So let's have our panelists introduce themselves. Where should I start? In my screen from the left, I'll start with Serena. Serena, would you like to introduce yourself?
For sure, thank you so much. My name is Serena. My pronouns are they, she. I am coming to this webinar with you folks from the unceded traditional Coast Salish lands of the Coquitlam, Katzie, Tsawwassen, Stolo, Wussainick, Kwantlen, and Semiahmoo nations, which is colonially known as Surrey, BC. I am a multiply disabled queer trans femme. I have pale skin, black hair that transitions into red with a plain orange wall behind me, and I'm wearing a black t-shirt. And I do disability justice work, I guess, through an organization that I helped co-found, the SFU Disability and Neurodiversity Alliance. And I'm so happy to be here, so thank you for inviting me.
Wonderful, thank you. Heidi, you're next.
Now prepared.
Hi, I'm Heidi Jams. My pronouns are she, her.
From
I'm coming to you from
the
traditional unceded land
of Ramona.
Ramona, can you read what I sent?
I can try, Heidi, but I'm coming from the traditional and ceded land. I don't see anything else in the chat box. Can someone else see what Heidi sent?
Sorry, of the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Sutro, and Azanabre nations. Over to you.
Super, Heidi, thank you. I'm sorry I couldn't find in the chat box. I'm sorry about that. Next on my screen, I have Dr. Leonie Herx.
Hello. So good to be here. So what an honor and a privilege to be part of this important discussion today, and I really appreciate the invitation. So I'm Leonie Herx, and I'm speaking to you today as a settler on the traditional territories of the Haudenosaunee Confederacy and the Anishinaabe Nation, and I am very grateful to be able to live, learn, and play on these lands. I'm a specialist palliative care physician and head of palliative medicine at Queen's University. I have a number of other roles, but my most important role is providing care for my patients and families who are facing significant life-changing diagnoses and facing the possibility of their own death through serious illness or a life-threatening illness, and the vulnerabilities that come along at that time in someone's life. And so most of what I have to say today, I learned from my patients and families, and I speak in honor of them today for what we need to do to ensure that palliative care services are available in Canada for those who need them where and when they need them. Thank you. Oh no, I'm going to describe myself. You can't tell, but I'm very short. I'm just over 5 feet and I have short, spiky brown hair. I am approaching 50 years old, so I now have these black, heavy reading glasses. So it makes my eyes look nice and big. And I have a black scrub top on because I'm working at the hospital today. So I apologize if I do have to turn my camera off at any point to answer a call. But again, thank you so much for having me.
Super, Leonie, thank you so much. Aasiya, am I saying your name correctly? Please go ahead.
Bonjour, Ani Kinigoya. My name is, or Aasiya Indishnagas, Aasiya Hussain. Meanwhile, Cohesion, Indonjiba Tukranto. Hello everyone, my name is Aasiya Hussain, and here with Cohesion in Toronto, the ancestral, unceded, and always territories of the Anishinaabe Mississauga. You know them as the Mississaugas. The Haudenosaunee, sometimes you know them as the Six Nations, and the Huron-Wendat. Here joining you as a survivor of colonial, intergenerational colonial violence, of medical ableism, racism, misogyny, and all the other intersections in the layers at which our diverse disability community are facing oppression that's driving us towards non-consensual made legislated genocide. I also lead intersectional disability justice, Indigenous justice, and racial justice and environmental justice with Cohesion. A very strong supporter of disability filibuster, and very grateful for all Indigenous peoples and for us all joining here. Really humbled to be able to hear the panelists who were disrespectfully cut off during a really important time of Canada's history. Miigwech.
Thank you very much. And last, but we'll then, why don't, actually we just launch right into your presentation, Dr. Gaines, Dr. Sonu Gaines. What do you think,
Ramona,
Catherine?
Sorry, just before we do that, I just want to flag, although she has her camera turned off and therefore may appear absent, Gabrielle Peters is very much with us and tuned in live and has submitted questions in advance. Gabrielle, as many of you will know, is one of the co-founders of the Disability Filibuster and currently one of its most indispensable leaders. It was Gabrielle who pulled this panel together on a really tight time frame when the inspiration to issue the invitations pressed itself upon our consciousness. Gabrielle, her pronouns are she, her. She resides on unceded and ancestral territory of the Hakanaman and Squamish speaking peoples, the Musqueam, Squamish, and Tsleil-Waututh nations, colonially known as Vancouver. Okay, back over to you, Leonie.
Okay, so I think we're going to start with Dr. Sonu Gaines. Sonu, go ahead, introduce yourself, and then go ahead and start your presentation. Thank you for agreeing to be here.
Thank you, Ramona, and thank you everyone for asking to have me here. It's a true honor to be able to talk with you. My name's Sonu Gaines. My pronouns are he, him, and I'm speaking to you from the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, and the Wendat peoples. And just before I get started in terms of the visual description, I'm a brown male. I used to have hair on my head. That seems to have shifted down to my chin over time. And I'm sitting in my home office surrounded by a lot of the things that I like in terms of, books, but also other kinds of artifacts and things from various cultures. And I think that we benefit from learning from each other. So in addition just to the land acknowledgement, I do want to say that I appreciate this being a safe environment for having open discussion. These are difficult issues we're talking about. And I really respect that in order to learn from each other, we need environments of safety where we encourage discourse and we don't stifle it. So thank you very much for providing that. we're all works in progress, and I look forward to learning from you as well. Now, what I will be doing, I have asked if I can do some slides, and I will assure you that what I've tried to do is that the slides aren't necessary for following what I'll be saying. They may enhance some of what I'm saying, but there won't be any material on the slides that I'm not able to convey verbally as well. And if it's okay, am I able to start the screen share if that's okay?
Yes, go ahead. We checked, I think, that it was working.
Okay, great, thank you. And don't worry, it's not something where I'll be going over all the slides, nor will it be something where this is not meant to be like a dry academic lecture or something. So just want to make sure it is now working. Is it showing what I'm hoping it's showing just as an introductory slide?
Perfect.
Okay, so basically the title of what I'd like to spend about the next 15 to 20 minutes speaking about what I've titled The Road to MAID Expansion in Canada, Which Mistakes Do We Want to Make? And that's a deliberately chosen title because I do think that often that's not how it's framed, and I think that's what we need to think about. I've put up a number of my disclosures here. I will let you know I'm not a conscientious objector to MAID. I actually am the physician chair of my hospital's MAID team, but I've become increasingly concerned about the profound dangers of the expansion that Canada is undertaking. I've been involved in various MAID-related issues, other than being chair of my hospital team, including having chaired the former Canadian Psychiatric Association Task Force on Assisted Dying. I was retained by the Attorney General of Canada as an expert witness in the Truchon Lamb cases. Lamb, of course, didn't end up going to trial. And I sat on the Council of Canadian Academies expert panel on assisted dying for mental illness. Having said that, my comments are my own. I'm not here representing any group that I've worked with. So how did we get here? And I'm just going to go through a very brief recap. I'm sure people are quite familiar with this, but I just want to remind everyone that all of this started such a short time ago, right? I mean, in 2015, we got the Carter ruling, and that basically said that the blanket prohibition against assisted dying violates the Canadian Charter. And it was for a narrow set of circumstances, people with neurodegenerative illness, and it included a provision that death needed to be reasonably foreseeable, natural death needed to be reasonably foreseeable in the initial safeguards. So Bill 14, C14, when that was crafted, that included that safeguard, which has since fallen. And the reason it fell was this ruling in Truchon, which in 2019 was ruled on by a single judge in Quebec. Again, a very specific set of circumstances that the two plaintiffs brought forward. And in this ruling, the judge ruled that the naturally foreseeable reasonable death criterion was overly restrictive, and therefore the country had to change it. And that's what led to the key changes of March 2021 in Bill C7. And just as a brief recap, the main change there was the creation of a second pathway to assisted dying with the elimination of the reasonably foreseeable natural death safeguard. And then what we have is a two-pronged system. One pathway where if death is reasonably foreseeable, the waiting period was entirely eliminated. And the second pathway, if death is not reasonably foreseeable, then there's now a 90-day waiting period. And the other big thing was that mental illness conditions, for sole mental illness conditions, the government implemented what they called a sunset clause, saying that within 2 years, by March 2023, there needed to be the provision to allow for MAID for mental illness, sole mental illness. I will point out that unique to Canada, we still have no requirement that treatment needs to have been tried for any of these conditions. There's a clause, as you know, in one of the requirements that the treatment that could relieve suffering needs to be acceptable to the person. And even in places like the Benelux countries and the Netherlands and Belgium, where people have traditionally thought, oh, those are more expansive. Well, even there's a requirement that treatment needs to have been shown to have been futile. In other words, there's no prospect of improvement. Here, we don't have that requirement. So what's ended up happening at this point? Well, right now we're anticipating the imminent release that was supposed to be on March 17th of the expert panel that is going to give guidance on how to implement MAID for mental illness. And again, this is an important point. They were not tasked with whether to implement or whether we should implement MAID for mental illness. They are tasked with providing essentially an instruction manual. One of the 12 people on that panel has already resigned, actually, and the report is, I guess, about to be imminently released because they got and sought an extension till end of April. Very brief recap on the numbers of where we're at now in Canada. The Canadian tracking system nationally is a bit lagging in terms of how quickly we get the reports because we only have data as late as 2020. In other words, we don't, for the country overall, we don't know what the full impact of the expansion in March of 2021 has been yet. But this is a recap of the data up till 2020. And you see that every single year, this is showing bar charts that show that from 2016 through to 2020, every year, there's been a pretty significant increase in the number of deaths by MAID in Canada. And it is at a point where, as of 2019, the overall national death rate was 2%, meaning 2% of all deaths in Canada were by MAID. And some provinces had significantly higher. Quebec at 2.4%, BC at 3.3%. That was 2019. When we look at 2020, every single province had an increase in the death rate. They actually call it a growth rate in the death rate, pretty remarkable term to use. But what ended up happening was the national death rate went up to 2.5%. And those other provinces that were high went even higher. So BC at 4%, Quebec at a bit over 3%. And again, this is before March 2021 C7 expansion. Some places like Vancouver Island have rates above 7% and has been dubbed the assisted dying capital of the world. So what's brought us here? And the rest of my time, I'd like to speak about this road to MAID expansion. And this slide shows the Wizard of Oz movie, going merrily along the yellow brick road. And, you know, I think that I hope people enter into these discussions with good intent, but the reality is that good intent isn't good enough. We need to have our policies based on reality and evidence. And rather than this nice yellow brick road to expansion, I think we followed what this shows, which is a broken road that's been paved with myths and failures of due diligence. And I'm going to go over a half dozen myths that I think have fueled this broken road. The first one being that mental illness is the same as other illnesses for the purposes of MAID. This is a very prominent one that people have said, oh, it's discrimination unless you consider it the same. Well, mental illnesses are very valid illnesses. They lead to terrible suffering and can be quite grievous suffering from mental illnesses. That doesn't mean that they're the same as all other illnesses, especially when we're talking about death and wishes for death. We know that when you have mental illness, the symptoms of illness can affect how we think. Think about it. When you're depressed, you don't think the same way as when you're not depressed. And research backs this up. We have decades of research showing that when we have symptoms of mental illness and depression, we tend to think we are bad. We think the world is bad. We think the future will be bad. Things that we would normally have some emotional resilience to, even regular life stressors, that we normally bend and react to, we lose that resilience, and instead of bending, we break. We tend to focus on the negative when we have symptoms of mental illness and are suffering depression. There could be good things around us, but we are unable to see them. And quite literally, some of these things are shown in research findings to also have physical correlates in the brain that show that certain functioning of the brain changes, including to the point where we may not be able to even envision a future. So think about what that means about when somebody is thinking about their place in the world and whether they want to be here or not. So this idea that mental illnesses are the same as all other illnesses is simply false. We have all sorts of changes in how we think. And I haven't even talked about the suicidality issue, which we will get to in a little bit. But the bottom line is that mental illnesses do change how we think while we're still competent. So capacity and competence is not an adequate safeguard alone against protecting vulnerable people who have these symptoms of death or suicidality. Mental illnesses are the only illnesses where suicidality can be a symptom of the very illness. And then the other one we'll talk about too, which is predicting the course. So this myth that mental illnesses are the same is simply not true. Mental illnesses are legitimate illnesses, but they are not the same on issues of MAID and death. So that myth falls. Now, one of the problems is that just like, that Hydra from Greek mythology, that you chop off one head, another one sprouts up. So another myth is that MAID for mental illness would be for relief of an irremediable condition, meaning something we can predict will not get better. That's supposed to be a fundamental safeguard in our MAID framework. Well, let's have a brief look at that. The Council of Canadian Academies spent over a year looking at this. We issued a almost 250-page report. And frankly, more telling than the findings were the areas of disagreement that we had. There were 5 highlighted areas of disagreement. And even in all this time, we could not find evidence of being able to predict irremediability in mental illnesses. I used to be the CPA president back in 2016 when the initial MAID discussions were happening. And at that time, we actually took this as a quote from one of the things that I wrote at that time, that there is no established standard of care in Canada, or as far as CPA is aware, in the world for defining the threshold when typical psychiatric conditions should be considered irremediable. Again, meaning when we can predict they won't get better. CAMH, completely apolitical, one of the most respected scientific institutions in the world, has looked at this issue. And they concluded there is simply not enough evidence for clinicians to ascertain when a particular individual has an irremediable mental illness. And the expert advisory group that I was involved in looked at the evidence again more recently, and we came to the same conclusion. So this is showing a slide for this expert advisory group report, which you can find at www.eagmaid.org. Remarkably, even groups that have advocated for expansion of MAID to mental illness, like the Quebec Psychiatric Association, they admit that it is possible that a person who has recourse to MAID, regardless of his condition, could have regained the desire to live at some point in the future. And then they go on to say that the certainty and eligibility criteria regarding those, that assessors will have to answer this ethical question each and every time they evaluate a request. I'm going to remind everyone that our law and the public promise and premise has not been that somebody has an irremediable medical condition if, in the ethical opinion of each individual assessor, they do. These things should be based on evidence and science. And if we're saying we can predict something as irremediable, that it won't get better, we need to be able to do that. And in mental illnesses, all the evidence shows that we cannot do that. So that myth also falls. MAID for mental illness is not for relief of an irremediable condition. And if it's not for relief of an irremediable condition, what is it for? Why might people seek death? Well, it is pretty obvious. People have reasons to potentially seek death for all sorts of suffering, including life suffering, including if they can't access care, etc. And then we falsely call it irremediable illness and provide MAID. That's pretty concerning to me. And this leads to the next myth, that expanded MAID is not suicide. Look at the power of language. MAID, medical assistance in dying, that was a new term coined by Canada when policy was introduced to assist in dying when death was reasonably foreseeable. In other words, when the person was actually dying. This idea that expanded MAID is not suicide, that we can't even say that word, is very troubling to me. Because quite literally, assisting or providing death to a non-dying person who wishes to die, that literally is assisted suicide. And the reluctance by people who advocate for expansion to acknowledge this simple literal fact is highly concerning. Think about how we compare this expansion vocabulary to our media reporting guidelines for preventing suicide contagion. In there, we talk about don't glorify the suicide, don't romanticize it, don't sanitize it, etc., because it can lead to increased suicide contagion. Think about how MAID is talked about. And quite concerningly, in the CCA report, they actually did find that there's evidence that shows overlapping characteristics of people who are traditionally suicidal and would benefit from suicide prevention instead of getting MAID, but overlapping characteristics of those and those who actually get psychiatric euthanasia in Europe. So that myth that MAID is not suicide, expanded MAID actually is assisted suicide. And that's not a pejorative term, that is reality. Moving on, marginalized populations are not at risk. That is a huge myth. This one is so concerning to me. This one is ignored so often. It becomes something where the only discourse becomes, oh, well, it's my autonomy to have it. And we don't talk about who's really going to be getting it when we expand MAID. So with expanded MAID, who seeks death for what suffering? Are we talking about different groups? And yes, we absolutely are talking about different groups, and evidence shows that. We know that when people get assisted dying for when death is foreseeable, they tend to come from privilege. So higher socioeconomic, educational status and privilege, and they tend to also be white. That's what the evidence shows. That's how the researchers describe it. However, when you expand to psychiatric euthanasia, completely different group gets it. That group lacks psychosocial resources. They have psychosocial suffering, and other sources of life suffering come into play, marginalized groups. Look at death rates from suicide in different populations. This is something not unique to Canada, by the way. Any country in the world that has Indigenous First Nations people where suicide rates have been studied shows that the suicide rates are way higher for Indigenous and First Nations populations. So the numbers here, I'll just read a couple of them. 24 per 100,000 versus 8 per 100,000. That's 3 times higher. And in some cases, much, much higher than that. And it's not just First Nations and Indigenous people, all sorts of marginalized groups, including LGBTQ2 spirited, show between 1.5 to 4 times higher suicide rates. And when you look at psychiatric euthanasia, you find that it is no longer a 50-50 gender balance of those who get assisted dying, unlike when people seek it when death is foreseeable. When you have psychiatric euthanasia, twice as many women as men get psychiatric euthanasia. That should trouble everyone. So again, different paths lead to people seeking death for different reasons. And so this idea that marginalized populations are not at risk, that myth also falls. Different populations are impacted differently as MAID expands, and marginalized populations absolutely are at risk. And then 2 more myths to go. And this is one that you kind of hope that when we have national policy developing, due diligence has been done. That is a myth. It has not been done, in my opinion. The parliamentary process was supposed to have a 5-year review initially. That was bypassed. The Quebec provincial court decision that was very unusually not appealed by the federal government. That was unusual in itself. And instead, there was this sunset clause that was recommended by the Senate. And then after 1 year, with mental illness excluded from C7 with the initial draft legislation, suddenly in February 2021, the government adds and accepts this sunset clause to ensure MAID for mental illness is allowed in 2 years. And in less than 4 weeks, so about 3 weeks later, Parliament votes to adopt this, largely along party lines. But interestingly, the party lines showed that both left and right were united opposing this. The Conservatives, NDP, Greens, and Independents voted against this after 1 evening of debate in Parliament. That to me doesn't seem like due process. Now, what about due process medically? Well, before we get to Canada, I'll tell you what other groups think about this. The American Psychiatric Association holds that a psychiatrist should not prescribe or administer any intervention to a non-terminally ill person for purpose of causing death. The Australian Association similarly does not believe that psychiatric illness should ever be the basis for physician-assisted suicide, and they consider unrelievable psychiatric suffering is rare, and that ensuring a person with mental illness has capacity in the context of seeking death may pose a challenge. And the Canadian Mental Health Association says, as a recovery-oriented organization, CMHA does not believe that mental illnesses are irremediable, though they may be grievous or unbearable. My own psychiatric association has put in significantly different input than that. I've critiqued this, and I've had some significant blowback as a result, but I will simply read what they have said and point out what they haven't. I will let their own words speak for themselves. So in March of 2020, the CPA leadership suddenly released a statement that included this comment: patients with psychiatric illness should not be discriminated against solely on the basis of their disability and should have available the same options regarding MAID as available to all patients. It was very interesting because it uses the idea of not discriminating, and we don't want to discriminate against anyone, but then it lumps it in by saying, well, they should have the same options available as MAID, assuming it would be discrimination if people didn't have that. And quite remarkably, a few months later, in response to some criticisms, they acknowledged that the statement was not intended to examine whether psychiatric conditions are irremediable, and if so, how this should be assessed. In other words, that hadn't even been looked at before this statement was released. And while officially the CPA says it has no position, it has characterized the exclusion of mental illness as inaccurate and stigmatizing, vague, arbitrary, and overbroad, discriminatory, and unconstitutional. And to me, quite remarkably, in all of the consultations, written and oral testimony leading up to C7, in all of those public consultations on mental illness and death, the number of times they issued or even said the words suicide, suicide risk, suicide prevention, literally zero. That is stunning to me. That's like a Respirology Association doing consultations on lung disease and not mentioning smoking. And in fact, when asked whether the CPA agrees with other experts that more research is needed in mental disorders prior to providing MAID for mental illness, the response was, I guess that's a legislative decision. To me, that's not providing clinical expert input or evidence. Other groups have raised concerns about this. Canadian Association for Suicide Prevention has said that the CPA is clearly taking a position on the morality of MAID, despite stating otherwise. Indigenous leaders have written, while claiming it's not taking a position, the CPA clearly supports MAID for mental illness. That's in their words. So reflecting on all of this, I had an earlier piece in the conversation in February 2021, where I concluded, and it's harsh to say, but I believe this is true, that in Canada's debate about medical assistance in dying, evidence has already been provided of medically assisted death. And so due diligence has not been done. And the very last myth, like the Hydra, until you find the last immortal head, you can't really deal with it. I think the last myth, and this is a big one, is that expanded MAID is about autonomy. What suffering leads to this? To me, this is not autonomy. This was from some work looking at why people seek psychiatric euthanasia. And it included things like perceived failures to live up to the expectations of others and the societal standards, norms, and feeling a burden to society, accumulation of several misfortunes and getting to a culmination point that's beyond the person's capacity to cope. That, to me, is not autonomy. But what autonomy are we talking about then? It's a different form of autonomy. I'm going to skip these because I can't really read all of this, but if anyone later does screen captures, you can go to these links that talk about the different forms of autonomy and how, in fact, it is not the same autonomy that people have when they are suffering from marginalization as if we live lives of privilege. To me, this is not autonomy. This is a headline from a podcast done of people in Canada, including one saying, "I die when I run out of money." So the idea that expanded MAID is about autonomy, it's a specific type of autonomy. This is from another piece in the conversation. And my conclusion was that expansion may be safe for the privileged who already live well and will have more autonomy to die better. For others, the non-dying disabled and marginalized, whose social suffering will be solved with death, it will eventually be called something else. So expanded MAID increases privileged autonomy. It's not just about all autonomy. So in summary, in few short years, the MAID framework introduced to provide compassionate relief from a painful death has expanded to an assisted suicide framework, providing death to escape a painful life. Canada now has the most liberal MAID legislation in the world with the fewest safeguards, in my opinion. Why do I say that? It's because of that thing that says treatment doesn't even have to have been tried. And no one's talking about forcing treatment, by the way. I'm not suggesting that. But before we know that something can't get better, we need to know what we're basing that on. And the idea that somebody who's never had access to even potentially attempts at treatment to get better, being able to get MAID is very concerning. And regardless of the range of opinions on MAID, evidence and due diligence have not informed policy decisions in Canada. My belief is that the new expanded MAID framework, it's gone from medical assistance in dying to socially assisted death or suicide, from MAID to SAD or SAS. And I think I will stop there and hand it over and look forward to the further discussion. I don't want to end on a down note. I think there are other positive things that we can talk about how we can try to engage and educate and hopefully change things later. So thank you very much.
Thank you, Sonu. That was amazing. I appreciate you coming today. We have a guest with us who has to leave shortly, Aasiya. I'm wondering if you'd like to share with us or ask questions, or we would like to give you some time before you have to go, and then we'll proceed with Dr. Herx's talk.
Towards Miigwech, thank you so much. So I guess I'll pose my questions ahead of time also for Dr. Herx, and then also share the questions for Dr. Gand. Please correct me if I or we are mispronouncing your names, which are sacred. In centering the most at risk, and the world hearing this from experts of privileged autonomy, kind of leading the reins in the expansion of MAID, and now with the newest proceedings and expanding towards youth as well. I have deep concerns in what we all know in Indigenous youth facing significantly higher rates of intergenerational trauma thrusting into suicide. And so when we know that this is not medical assistance in death, but medical coercion, structural, systemic, colonial, legislated coercion into suicide, pushing people who are at risk off a cliff, instead of supporting the needs that one needs to live and thrive. My questions to both panelists are, how can we get to a place where, as we see in different countries, autonomy can be true, where offering such a thing at this point is not benevolence, it's coercion in many people's view in our disability community. But how do we get to a point where everything that we need to thrive is actually mandated as required to be offered and benefited from before being offered such a final thing, and to the people who are at the most risk. And my second question is recognizing and observing all of these proceedings, and also the thunderous applause in politicians passing the expansion of MAID to C7, which specifically and only targets people with disabilities without a foreseeable death. It gives the impression to so many people like me and many others that our lives are not worthy. And as I'm continuing the question, I want to speak directly into the audience. As a brown woman with white hijab and gray and white stripes in front of a tan wall and drum behind me, that you are worthy. You are worthy of everything that you deserve and need to live and thrive with dignity. You are worthy. You are worthy. You are worthy. And for advocates and specialists like yourself, the doctors who are joining, and all of us who are witnessing the proceedings, we're also witnessing what Dr. Gand had mentioned about privileged autonomy. And my concern is also in privileged fragility, having internalized ableism, and how that impacts also when you're experiencing grief, perhaps witnessing loved ones in long-term care who are experiencing apartheid and lack of proper palliative care, as Dr. Herx specializes in. And so that internalized ableism also that dehumanizes people with disabilities is unable to perceive approaching or even living disabled life as worthy, as joyful, as having what we need and deserve to live with dignity. So why not dismantle, if people are afraid of long-term care, why not support what we need to age in place at home and have access to palliative care, right? If we are being denied pain medication and it's reached to a level that we can't imagine the next breath because it is that excruciating, why are we not dismantling the barriers to pain medication? And I know that both of you as specialists have been trying to dismantle these barriers as well, but if you can help the audience who may not recognize this and maybe pushing towards what is disproportionately causing more disparities and harm on the most at risk, if you can comment on this and what you think we can do to decolonize this oppression and introduce mandatory supports before being forced into such a grave situation where, for example, murder or death or genocide or whatever you want to say, coercion or suicide is not the prescription for mental illness, is not the prescription for an unforeseeable death where treatment is possible and can be made available and is prioritized to be received. That's my question.
Thank you so much. Would someone like Leonie or Sonu, who would like to start? You raise your hand. Does anyone want to start? Either of you? Go ahead, Sonu.
I'm happy to start, and Leonie, please, you'll chip in afterwards, I hope. But thank you very much for not just your question, but your words and sharing, because I think that it is something that the question you're asking is often forgotten and not considered. You know, and I think part of the way I'd answer what you're saying is that the very questions we ask need to change. And what I've found is sometimes there's a reluctance or resistance to doing that or to asking the right question. Why? Because some people may not like the answer to it. But what it also shows is they don't have good answers to it. And so in terms of one of the questions, actually at the beginning of my talk, the question was, which mistakes do we want to make? I've changed that question. I used to end, back in 2016, I used to end talks in a bit of a different way. And I had a picture up of things balancing in an intricate model that was like finding a perfect pivot point. And the question was, where do we want the fulcrum? Implying that, there's some perfect point that everything can be met and accommodated. I don't believe that's possible, especially with something like this, where we're expanding the availability of easier death to people who have terrible life suffering. Then the question needs to be, which mistakes do we want to make? And by that, I mean, and this is a very uncomfortable question, I think, for policymakers to answer, that would you rather have policies that say that in some situations, maybe somebody who we quote unquote think should be able to get made can't because there are some safeguards in place? Or would you rather make the mistake that people who we absolutely know shouldn't be able to not get made, but shouldn't be provided death for life suffering and marginalization, they end up getting it? Who's going to answer that question saying that's the mistake I want to make? And so we need to shift part of the conversation to force those questions to be the ones that are demanding answers, and getting to the point of providing death as an escape rather than providing means of living with dignity as what we should be doing. I absolutely agree with you. The idea that we think death is a solution to this suffering when we haven't helped people live better, I think that is terrible. I will say, I think things can change. And part of that, it involves a lot of work. If honestly, it feels like bumping up against a wall constantly, but you see it sometimes pushing back inch by inch, that wall. You know, I had actually spoken at the Irish College of Psychiatrists when they were debating how they would deal with this issue there, and asked an awkward question, which is, are we talking about compassionate medical assistance in dying or negligent social suicide promotion? Again, it's a harsh question, but it casts things in a particular light. And, you know, they already had a very deliberative process. I'm not at all suggesting that this is what changed or shaped their minds. They already had a lot of thought given into this, but they responded to those sorts of questions by saying this is what it's about. And they actually weighed in December saying, I'm going to read this to you, but it gets to so many of your issues here, that where assisted dying, we are acutely aware of the sensitivity of this subject, acknowledging that. We understand and support the fact that dying with dignity is the goal of all end-of-life care. Strengthening our palliative care and social support networks makes this possible. Not only is assisted dying or euthanasia not necessary for a dignified death, but techniques used to bring about death can themselves result in considerable and protracted suffering. And they conclude saying, where assisted dying is available, many requests stem not from intractable pain, but from such causes as fear, depression, loneliness, and the wish not to burden others, carers. With adequate resources, including psychiatric care, psychological care, palliative medicine, pain services, and social supports, good end-of-life care is possible. And if that's not what we're doing, I think we are feeding into internalized and externalized ableism, ageism, sexism, racism. Put in any sort of ism that you want there.
Can you hear me okay? I'm not sure I have, that was so eloquent, Sonu, thank you. I would say some practical things maybe that we need to advocate for in terms of changing the dynamic and the dialogue that we've created in Canada through the way the legislation has been implemented and structured, is that there's this real kind of juggernaut movement towards, as you said, that privileged autonomy is driving it. So we have like these wealthy, well-off, white, worried people in Parliament setting policies that impact, unfortunately, the people that don't have access to the adequate resources needed to live. But it's those same people that are also setting that, well, we have a right to self-determination and you must inform us of all our options. So now the push is to say that doctors must recommend or bring up, which is often seen as a recommendation when a doctor suggests an option to a patient, to all potentially eligible patients in Canada, which with the most permissive MAID laws in the world means currently almost all adults, because there are very few, and Sonu can speak better to this, but very few cases of MAID where it's just a mental illness at this point. Like there's often some other chronic illness or disability that a person lives with. It's just part of being a human that would make you eligible. So there aren't a lot of conditions currently that are strictly that people live just with just a sole mental illness. So right now, almost anyone who's an 18 and over could have irremediable suffering from a grievous condition. So that would be like doctors bringing up MAID as an option to all of our patients. For me in palliative care, that would be me having to say, you know, you could have this and this, or you can have MAID. And I know countless patients who have requested MAID because their trusted clinician or physician brought it up to them, so they thought they were going to have this terrible suffering and they better request it. So one of the things that I think we as a larger community need to advocate for is that physicians not be allowed to bring up or recommend MAID to anybody unless the person asks about it. And other jurisdictions have done that, such as in Australia. And then the other piece is that we need to advocate that access to MAID as required through the legislation does not require it to be provided in all places. It does not happen for any other procedure. We can argue whether it's a medical procedure, but let's just say they've called it a medical procedure in the country. It's not provided in every setting of care. There has to be spaces that are safe for people who don't want to feel coerced into getting MAID or feel that they might have it provided without their consent. If a long-term care, other type of residence, hospice, palliative care, hospital area chooses not to provide MAID, they should be supported in doing so that patients can have a safe place to go without being pressured into MAID. So I think those are a couple of concrete suggestions that I would love to see some national advocacy on. And we did try during C7, and we even, you know, there was some political movements to suggest amendments that were defeated, but defeated by, again, those people who are from a privileged autonomy perspective, not thinking about the bigger picture and the harm. Like you said, I would like to think of it, how many wrongful deaths are too many? I would say one. We should not have one wrongful death if we have proper policy around this type of legislation.
Thank you, Leonie. Leonie, we're going to ask you to go straight into your presentation.
Okay, thank you. And I think I always have a lot to say, so I'm happy to be interrupted if I'm talking too long and it's not of interest to everybody. I'm very flexible with what I chat with you all about today. But really, again, just thank you for the opportunity to be a part of this important panel discussion today. And I thought I would start by reviewing with you the differences between palliative care and medical assistance in dying or euthanasia and assisted suicide, because I think it's not well understood, and there's many reasons for that, which are contributing to some of the things we're seeing in the committee meetings and the way this has unfolded, and also discuss how MAID is impacting our clinical practice in palliative care, as well as just in medicine, being doctors. So palliative care is a holistic approach to care that focuses on enhancing the quality of life for persons living with any type of life-threatening illness and their families by means of early identification, impeccable assessment and treatment of symptoms, including physical, psychosocial, and spiritual, and supports a person in living well until they die, or medical assistance in living, as I like to call it, and some of my colleagues as well. Early integration of palliative care has been shown internationally through robust studies to improve quality of life, reduce anxiety and depression, reduce caregiver distress, and in some cases helps people live longer. An integrated palliative approach embedded within all care for people living with serious illness soon after diagnosis must be provided to help people live well. But due to the ongoing stigmatization and misunderstanding of palliative care as end-of-life care, it's often only considered as an extra therapy in those last weeks of life. Only about 30 to 50% of Canadians who need it have access to some kind of palliative care of unknown quality, and very few, only about 15%, have access to specialist palliative care to address more complex issues. There are significant disparities in the ability to access palliative care across the country, especially in rural and remote regions who may have no palliative care at all. Whether you will get the palliative care you need depends on where you live, how old you are, what you are dying from, and how close you are to death. You are also less likely to receive palliative care if you are poor, Indigenous, homeless, or incarcerated. When patients' palliative care or persons' palliative care needs are not met, the ensuing physical, emotional, and spiritual suffering can lead them to feeling depressed, hopeless, a burden to others, and can result in a desire to die. These are the factors that drive requests for MAID. This has been shown in Canada and consistent internationally. So even in the setting of someone with a life-limiting cancer diagnosis, it's not their uncontrolled pain or shortness of breath that drives a request for MAID. It's these other factors. The earlier that palliative care is provided, the better the prevention of suffering that leads to distress and despair. Earlier palliative care must be provided to ensure that the suffering is addressed before it becomes irremediable. Failure to do so, as asserted by my colleague, Dr. Romaine Gallagher, palliative care physician, and her colleagues as well, should be seen as an egregious medical error. Although the Health Canada reports on MAID have drawn the conclusion that there is no issue with respect to palliative care and disability supports for those accessing MAID, many experts have refuted that this data, which is collected from self-reports of MAID providers, is inadequate to draw such conclusions. What we can see with further scrutiny is that, and even within the limitations of this type of self-reporting, is that over 35% of patients had little to no palliative care prior to their MAID request. This is consistent with the results of a Canadian study by Monroe and colleagues in Ottawa in 2020, which showed that 40% of patients had no palliative care involvement prior to requesting MAID. This is even more problematic in the context of the C7 legislation and the removal of the 10-day waiting period, where there will be higher numbers of those not receiving palliative care now, since the impetus to call palliative care is not there. I'd like to spend a few minutes now, if that's okay, to explain the differences between MAID and palliative care, as some non-palliative experts and politicians, including members of the Special Joint Committee on MAID, continue to erroneously describe them as being part of the same continuum of care. They are not. Palliative care fundamentally differs from MAID in its philosophy, its intention, and its approach. It is internationally and nationally recognized as a practice distinct from MAID. The national colleges responsible for setting the standards of training and competencies for the specialized discipline of palliative medicine have very clearly defined the role of palliative medicine in addressing suffering, and in keeping with the international standards for palliative care, it does not include hastening death. This is reflected also in the Health Canada framework for palliative care in Canada and the new Canadian interdisciplinary competency framework for palliative care that includes both primary and specialist palliative care competencies. Unlike what seemed to be inferred at the Special Joint Committee meeting last night, people cannot just randomly decide what is part of a medical specialty or not according to their own preferences. Discipline standards are set by the National Professional Association, such as the Royal College, who oversees the medical education of specialists in Canada, and who are responsible for accrediting the university programs that train physicians for their specialty practices and setting the credentialing requirements for specialist recognition. Imagine a politician saying that anyone can determine what should be considered part of the practice for surgery and that we do not need any standards to guide the practice. That is what was said about palliative care last night, and it is absurd. There are several factors contributing to the ongoing confusion between palliative care and MAID in the public realm, including the use of euphemistic language, the perpetuation of long-standing myths and stigmatization of palliative care as a death service, and the lack of awareness about what ordinary dying looks like. And I'll just briefly go into these three issues. So first, the euphemistic language. The term medical assistance in dying, or in Quebec, medical aid in dying, is misleading. MAID is not care for those who are dying under Canadian law. It's not care, but it is a procedure for those who want to become dead. It is not end-of-life care, but ending of life. Palliative care itself provides medical assistance to those who are dying every day to help them live with the best quality of life until their natural death, but it does not intentionally end life. Many people think that when they ask for medical assistance in dying, they're getting palliative care. I see that on a weekly basis in my practice. So I think to more clearly differentiate palliative care from what we call MAID, euthanasia and assisted suicide, we need to start calling palliative care medical aid in living or medical assistance in living, MAIL. Education on palliative care is critical to help dispel the myths that continue to be perpetuated that palliative care already hastens death and there is no difference between MAID and palliative care. For example, that giving opioids for pain or shortness of breath at the end of life speeds things along, or that palliative sedation is the same thing as MAID. Opioids and other medications used in palliative care are carefully titrated for effect and side effect, and they do not hasten death when used appropriately. Palliative sedation is a specific intervention used by palliative specialists in very strict circumstances in the last days of someone's life to control refractory symptoms. International studies have shown that when used according to these very careful guidelines, it does not hasten death. And third, there's a lack of comfort and awareness about what ordinary dying looks like. This has resulted in fear around not only dying, but aging, dying, and death, because it is so unfamiliar to many of us. Our society often removes those who are frail, elderly, or dying to institutional settings. Many medical students can graduate now without even having been at the bedside of a dying person. Many people are not aware that the normal physiologic process of dying need not be scary. Education can help families know what to expect and change their fear and negative experiences. How pain and symptoms can be controlled while dying with high quality palliative care. Many people are unaware of that, but we can do an impeccable job. Many people are not aware as well that a person can choose to stop or not start futile or burdensome treatments when they are no longer benefiting a person, or if there's no reasonable hope of achieving benefit. For example, dialysis, antibiotics, chemotherapy. Stopping or not offering futile medical treatments is not the same thing as euthanasia. Palliative care clinicians regularly hear expressions of a desire to die or requests for hastened death. These are most often expressions of grief, anger, loss, or despair as an expected response to getting a devastating diagnosis or a change in your condition. Talking about wanting to die can be a normal process of coming to terms with the possibility of one's death. And most often this is a cry for help and not a request for a lethal injection to end life. And we know that this desire to die often goes away with adequate support. Dr. Harvey Chachanoff's work, and he spoke last night at the committee in psychiatry and palliative care, demonstrates that desire to die in the terminally ill fluctuates and often dissipates within 2 weeks. We can talk further about what that means when now we remove the 10-day waiting period and people can have same-day MAID. In palliative care, we have a unique role through our specialized training and expertise to address suffering. We work diligently through whole person care to accompany a person in their suffering and to dig deep to understand what is going on for that individual. Through evidence-based therapeutic interventions and creativity, we can reframe hope and restore dignity and a sense of well-being that tells a person that they matter for who they are, not what they can and cannot do. As Dr. Balfour Mount, the father of palliative care in Canada, describes from one of his patient encounters, the possibility of sharing the load had suggested a glimmer of hope for new light and lightness. The mountain ahead might be steep, but it might all become possible. Unfortunately, what we're seeing now is that a normal lament or expression of grief when facing a life-altering diagnosis leads to a MAID consult before palliative care has even been involved. As I mentioned in that recent study, and even in the Health Canada data, we can see that up to 40% of patients who got MAID had no palliative care prior to their MAID request. According to Dr. Nuala Kenny, research shows that when euthanasia is legalized, doctors respond to cries of anguish and desires for death by initiating processes of eligibility rather than reassessment of all aspects of care, so death becomes the treatment. MAID was intended for very extenuating circumstances, not as a routine option for ending life, as a solution to any suffering that could be addressed through health and social supports that help people live a dignified life. As we've just heard, now under the C7 legislation, MAID is offered to those with chronic illness, disability, and as of March 2023, mental illness as a sole diagnosis. And we're currently studying further expansions to MAID for mature minors and advanced directives. Since Bill C7, we are seeing countless cases in the media. I know you are all aware of them, but in our own medical practices as well, of people requesting and receiving MAID due to a lack of basic supports needed for living, including lack of palliative care, home care, and disability care. As the Disability Inclusion Minister, Carla Qualtrough, herself said last year during the C7 deliberations, in some parts of Canada, it is easier to get access to MAID than it is to get a wheelchair. MAID has been deemed an essential service under the Canada Health Act, with a guaranteed right to access, but palliative care, home care, and disability supports are not. Currently, Canadians have a right to medical assistance in dying, but not a right to medical assistance in living. I'll end with a couple of final thoughts, and there's lots more things we could talk about, but maybe we'll cover some of it in the question and answer. Just about how MAID law is impacting the practice of medicine, and Sonu referred to this earlier, but under Canada's MAID legislation, patients requesting MAID need only to be informed of other options. There is no requirement for supports or therapies needed to live to have been tried or even to ensure that they are available as an option. This raises to me a serious question about what constitutes informed consent, and is it truly an autonomous choice if there are no viable alternatives? For example, you live in a rural remote region and you have no home care. You might have to leave your community to be able to get the care you need, or choose death. We know people who have chosen death because they didn't want to leave their remote rural community because they didn't want to leave their family. As Dr. Harvey Chachanoff said at the committee meeting yesterday, and I'd like to quote him, "Exercising autonomy means having real and viable options. If you are dying in the absence of quality and available palliative care, if you are disabled but don't have access to supports and services or social housing and employment opportunities, if you have chronic pain or uncontrolled symptoms and don't have timely access to a specialist, if you are struggling with a mental illness and can't find a therapist who is prepared to help you work your way towards accommodation, rehabilitation, or recovery, can we really say you are exercising an autonomous choice?" In other countries, as Sonu referred to earlier, clinician-administered death outside the end-of-life context, death must be a last resort when no other options for care remain. But our legislation allows death to be provided as a first-line option, and thereby sets us up as the most permissive assisted death regime in the world. One last thing before I finish. As we've mentioned during the question and answer, we're also seeing this push for doctors to bring up MAID as an option for any potentially eligible patient. So anyone facing a disability or a new diagnosis of a health condition can be offered death even at the time of diagnosis, when they might be at their most vulnerable. A doctor offering unsolicited MAID as an option to a patient may be all the push that is needed for that person facing that vulnerable time of their life to pursue it. Patients take the recommendations of their doctor seriously. In my opinion, and as seen in some other jurisdictions, discussion of MAID should be explicitly patient-initiated to minimize the risk of coercion. I'd like to end with a quote from Cicely Saunders, who founded the hospice palliative care movement. "You matter because you are, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to help you live until you die." Thank you.
Two amazing talks. Catherine, do you want to share something?
I am absolutely overcome with gratitude for the clarity and the courage that these physicians, and I'm going to include you, Ramona, in that category. You and Sonu and Leonie have stood for and stood by truth and evidence, and that truth and that evidence is very much in support of all that we are trying to affirm and bring to public attention. And the fact that you have stood in this way has had consequences. I have no doubt for each of you. And that you have tasted some of the ostracization and the dismissal and the gaslighting that we have experienced and know well. And so I just want to take a moment to honor your presence here and to say that, so much of our fight is about uprooting ableism and confronting it in the centers of power in our society. One of those centers of power is healthcare. And so we are in many ways more accustomed to having to fight to be heard when we speak with medical professionals, to establish our credentials, to bring ourselves up to a great enough strength to be heard. And yet here you are, and it's very different. And so for standing out and for standing up for truth and evidence and ultimately for justice for all human beings throughout the course of our lives, I just really want to thank you. And I'm like you, Ramona, looking forward to hearing more from what other panelists have to say in response to this great clarity and this great broad sweep of myth busting that we have just witnessed. So let's hand things over, shall we?
Yes, that's exactly what I was thinking.
Yeah, we appreciate. Yeah, go ahead, Ramona.
I was going to say, Serena or Heidi, would you like to start by sharing your comments or your thoughts on Leonie and Sonu's presentations or anything?
Yeah, I'll go.
Yeah, I'll go.
The double that you do.
First of all, thank you all for amplifying our voice
not being heard.
at a time when our voices aren't being heard. Something that really struck me is that as I watched some of the testimonies, specifically Leonie's, was the difference how they treated you and how they treated us disabled folks. When us crooks testified, and there was questions, nobody opened their mouth. Except to pat us on the head. And thank you for telling your stories. Not evidence, stories. But when you guys testified, see your tabs. So the decision makers don't look like jerks if they come after you. So what I'm saying is, if that isn't a portrait of ableism in Canada, I don't know what is.
No, I do have a question.
Who Leonie.
You got yeah, my feeling of just
You brought up made being a choice
only for people
only for people that are already died. No, privileged.
Yeah, if out with right people who don't want to be on maybe they out
It's basically a note for people that don't want to live like me.
with white people
Rich white people
who
who don't want to live
like
like me.
and they um thank you for the of making both of that reality.
Do you think there's any way of how to expose that reality?
That will make Canadians finally
That will make Canadians finally see it?
all that is a lot of
Or is that just a lost cause?
You know, I think that the stories are what's important, and we're starting to see more of the stories being picked up in mainstream media, right? So we've had the woman with the chemical sensitivities, and the story of Donna who didn't get proper mental health treatment. And I think the more stories we can share, because there's many more stories that are not being told, the more people will understand the dangers and what's happening, because what they've heard is a very one-sided, biased approach so far in the past 6 years of these romanticized deaths of the white elderly couple who want to die at the same time. They can't imagine living without each other, and the farmer who goes out and gets, euthanasia in the field. Like they have this romanticized sense of this is this beautiful way to die, not the actual reality of what is being lived on the ground. So we need to share more stories, and we need to have open dialogue. And if we want to talk about what's happening, in the situation of MAID in our workplaces, in our communities, we should not be seen as trying to obstruct access and be bullied and marginalized, which is what currently happens, especially within the medical culture, but I'm sure in every community, that if you want to talk about the harms and the risks and something that's happening that's not right, you're just labeled as being anti-MAID, and the conversation is shut down. So we also need to change that dialogue, and like today, create a safe space where we can actually hear and listen to one another and understand what's going on.
Thank you, ladies. I'm going to move on and give Serena a chance also. Serena, would you like to share with us what's on your mind?
Thank you, Ramona. Yes, and thank you for the presentations. Like I said earlier, it brought a lot of clarity for me on this topic and on the themes of socially assisted suicide and not being able to access the resources that we need to live. I thought about my experiences, and I'm sure the experiences of countless other disabled folks as well. I requested to see a psychiatrist recently, and by recently I mean last year. And I haven't gotten an appointment until I advocated for it this year, and they said, oh, we can give you one in June, so maybe 6 months out. And I reflected on it while folks were speaking, and I thought maybe I'd be able to see a healthcare professional more quickly if I was seeking death instead of healing. And maybe, this is just the state's way of letting us know that, we've been trying to do this for years by not providing you the adequate resources and pushing you off to the fringes of society where we have to suffer on our own, but now we're going to formalize it. And, you know, I think about folks in my community. There's a lot of over-policing in my community, and recently a community member was murdered by the RCMP mental health outreach team. And I was thinking about it, if, you know, the state isn't successful in murdering us within our homes, within so-called wellness checks, what happens when we're brought back to a hospital? And are we offered that same death? And are we offered that same death when we survive that experience? And how are we going to survive the experiences of being in healthcare institutions now? And to speak on the topic of suicide, you know, I've been actively suicidal before and certified for under the Mental Health Act and that kind of thing. And I don't see that there's a clear understanding of where suicidality begins and ends, and where quote unquote medically assisted dying begins and ends. You know, there's a lot of experiences that I've had where, you know, people have suggested that perhaps that I'm untreatable or being non-compliant with treatment because there's no success being seen. And I'm worried and scared for all of us that now that this option is available, that folks won't even seek healing. And by folks, I mean like medical professionals will seek death as the first step as opposed to healing, because there is no need to heal folks that you don't believe are of the same value as you. And we know how prevalent ableism is, and, you know, being put in these kinds of institutions. And, you know, I've said that life is unbearable, and, you know, that I wish I wasn't here, and all of these kinds of things, and that, you know, life isn't ever going to get better. And I was wrong. But in the moment, I truly believe those things. And I think if I was provided, there's been multiple times in my life where if I was provided the option for death, that I would have taken it. Because I was experiencing so much stress and I didn't have the resources that I need. And I know that's the experience of countless other disabled folks as well. And just to see the lack of empathy and understanding, even around just, I was watching the committee meeting the other day, and even just the lack of understanding and stigma around, oh, like, you know, people who commit suicide are destructive, but we're doing something productive here. It was honestly so unnerving that I don't know if I have confidence that healing will ever be available to me under so-called Canada and the institutions that exist within it. But I did want to ask, perhaps folks have more knowledge on me on this topic, but how would it be addressed if someone is suicidal and they're also seeking mate at the same time? Like, where are those lines drawn? If it's not suicide and someone's suicidal, are you not giving in to their suicidal ideation? Like, I honestly don't have an understanding of where one begins and the other ends.
Maybe I could just briefly say, Serena, first of all, thank you for your sharing. That was, all the panelists had something so important to say, so much to add to this conversation. As a doctor who takes care of patients living with disabilities, I'm very distressed to say that suicidal ideations that before were being met by suicide prevention now seem to depend on the ideology of the doctor that they meet. So I can share without any details, but I have a very young, lovely female who has heart failure. She had she has an idiopathic heart disease, and she became suicidal, and she ended up admitted at our local hospital. And the initial psychiatrist informed her for her protection. And the next psychiatrist released her and wrote in his notes, or her notes, luckily I don't remember, I was very upset, that she has the right to end her life. And so instead I had to call her family who don't live in town, and many people had to rush, and we had to come up with a home plan, a home safety plan, because none of us felt that the hospital was safe. I am seeing patients who are having strokes, especially during COVID, where they're not allowed to see their family, which is difficult in itself. And then, of course, you can understand that there is a very high rate of new depression and grief when you have a new diagnosis of disability, when you're learning to adjust, right? And they are being offered MAID in that acute state. And I don't want to get into the details, but they're figuring out ways to get them into track 1 so that they receive MAID while they're still on the ward after just having a stroke, like days after having a stroke. Not being offered by the neurologists who have expertise in recovery and rehabilitation, but often by acute care doctors. I'm not knocking acute care doctors. My husband is a surgeon, but there does seem to be this kind of dichotomy in medicine of doctors who have experience in rehabilitation and recovery and know and love many patients with disabilities, and doctors who might only see patients in this very small frame of time when their suffering is at its peak, who think that they're compassionately offering death when actually they don't have experience. I say all this, I'm not trying to scare you. There's a lot of good doctors still out there, but Bill C7 is terrifying, and the way that it's rolling out already in my community is terrifying to me. I don't know, Leonie or Sonu had to sign off, I think. Oh, Leonie, do you want to quickly answer? And then I think we'll turn to panel questions and Gabrielle's questions.
Sonu's waiting to speak.
I don't see him. Oh, there you are. Sorry. Go, Sonu, go.
Thanks, Ramona, and Serena. Thank you also for your bravery, because you've struggled to get through to a better place as well at times, and I think that's always important to remember, because you're absolutely right. This is part of the concern, that in those moments it looks like nothing can possibly help, and we can convince ourselves of that, and this is why we need to change the narrative as well, because I think people don't see that. I honestly don't think, I really don't think, that if most Canadians understood what was going on and why people will really be getting this and who really is at risk, I don't think most Canadians would actually say, oh yeah, we'll trade that for privileged autonomy. And this is why getting the narrative out and the stories out and changing the narrative is so important. I've actually literally seen that through this. I've had experiences with people who initially thought, oh yeah, it's about autonomy, what's wrong with that? Why? And then discussions with them, and they completely have changed their minds. I think all of us who've worked in this area have. Actually, that includes one newspaper editor who actually, and for them to say that, that's pretty remarkable, to say that, oh, you know what? I've actually changed my mind on this. I think so. As we get those stories out there, I think that is where the hope lies, because the risks really are there. And I have to believe this, that most people, this is what we do for each other, right? When we are down, when we're down and out, we help each other get up, because at a different point, it's going to be me that's down and out, and I will appreciate your help in getting up. I think that's what most people actually want, but that's not the narrative that's been out there. And that's why it's so important to get more and more awareness out there, not just the false narrative that's been propagated.
Leonie, do you have anything to add?
Just a small point for discussion, and I think another point to raise awareness, because again, we're not really talking about what is happening on the ground, but it is becoming more common, as I've heard from MAID providers, that someone who it would be track 2 by the definitions, who are choosing not to get their condition addressed in some way or treated, are being moved over to track 1. And I think that's something that needs scrutiny and monitoring, because we don't understand, but it's referenced to in conversation that, oh, most of them get moved over to track 1 because their death becomes foreseeable because they're not having their condition treated. And I don't think that was how this 2-track system was intended. I would be very surprised, but it seems to be happening fairly often. And that's very scary and dangerous. We do see people getting same day MAID like that. We talked about that during C7, and I have a famous quote that on your worst day could become your last day. But that's now happening for people whose death is not reasonably foreseeable, who are choosing no treatments and being moved over.
Okay, I'm going to go ahead and read. Gabrielle Peters had a question. Is that appropriate? I'm going to read her question. It starts based on Sonu's testimony. So if you weren't there or didn't get to listen to Sonu's testimony at the Parliamentary Committee, I'll go ahead and read that. Okay. So she says, I'd like you to comment, I guess it's to the panel, on something Dr. Sonu Gaines said at the Parliamentary Committee, which I think is powerful and significant. You said, no drug company is told their sleeping pill will be approved in 2 years without evidence or effectiveness of safety, while being asked to develop instructions on how to use the pill in the meantime. The sunset clause in the federal panel's mandate is based on less evidence than required for introduction of a sleeping pill. I was wondering if you could expand on this point, and in particular, the selective way evidence is being invoked in this discussion. Someone that struck out for me leading up to the passing of Bill C7 is that whenever a disabled person spoke and shared their own or disability community knowledge, it was dismissed. In contrast, I remember a proponent of MAID testifying and being accepted as credible evidence that they could guarantee that 100% of their colleagues would 100% of the time be able to screen in a way to distinguish suicidality versus MAID, socially and politically created suffering, and despair versus medically caused suffering. Situations where domestic violence or family may be pressuring the person to consider MAID, etc. Evidence like knowledge and expertise has been defined by those with power in a way to limit whose knowledge and whose expertise is defined as such. It also is constructed in a way that requires material resources to collect and analyze. I was wondering if you could speak more to that. So I think the question's directed at Sonu first, and then maybe other people's comments.
Sure. Thank you, Gabrielle. I'll be brief to allow others to comment too. But what I meant by that was that, even for a sleeping pill, and I deliberately picked an example of something that people think is, it's relatively innocuous. Although, having said that, they're not necessarily innocuous. You can actually get hooked on them. So that's a strong caveat. But my point was, stuff that we have in society that is seen as relatively innocuous has a scientific process it's supposed to go through in medicine. And it includes showing, is it safe? What harms could be done, et cetera, et cetera. And it's a lengthy process. So what I said is literally true, that any sleeping pill that is available in Canada has gone through more evidence review than MAID expansion has. Why do I say that? The MAID expansion, it was one evening of debate that was foreshortened through closure last March to introduce this so-called sunset clause. The sunset clause is a prime example of a complete failure and abrogation of the need for evidence, because it's saying in 2 years, we will do this without having any clue about whether it's safe to do. And even worse, I would say ignoring evidence, because there is evidence from the European countries that allow psychiatric euthanasia, that more marginalized people are at risk. So if you want to know this is my personal opinion on it, but I think something like the sunset clause is put in not in the hopes of having evidence-informed policy, but to allow policy to be implemented despite evidence. It's a way of setting up something as saying, oh, it's a fait accompli, it's a done deal, don't bother, I'm trying to change it because it's already going to happen. We would never do that in medicine in any other way. And so these discussions we're having, they are important because it's needing to raise awareness that the sunset clause itself is something that is completely a house of cards. And the sleeping pill analogy or example is meant to illustrate that, because I quite literally meant that when I said that.
Well, I'm just thinking in terms of time, Catherine, do you think we should move to panel questions? Do we have time for that, or?
If we have one, let's do one, Ramona.
Okay. I think I'll start with the first one, to be fair, just because I think there's 6 of them, and I'm sorry that we're not going to get to them all. But the first question I think that came up was, how do we deal with patients or help families of patients who are looking for medical assistance and dying because of years-long waiting for a psychiatrist? Or I guess we could insert any care that would lead to desperation and wanting to die as needs were unmet. Does anyone on the panel have some helpful solutions? It definitely doesn't have to be the doctors. Anyone else want to also give some input on how they might have, how they help people navigate the system? No? No one else has something? Just okay.
I don't want to leave the question unanswered, though, Ramona.
Yeah, go for it, son.
Well, I mean, I would just, and maybe others will chip in as they're thinking about stuff. But, one thing I would say is we don't abandon people. This idea that, so I think it's terrible that somebody would have to wait years to get help that they need. I think the focus has to be on actually trying to help people get that help that they need. So I can't speak to a specific situation because I know that there are long wait lists and problems that need to be addressed in the health system. I'm not defending that. That has to improve. I think it's highly dangerous, however, if the response to that is, okay, well, because people can't get the help they need, we're going to help them end their lives instead as a solution. That is, that's highly dangerous. I don't think it's moral or responsible to do that. So I think we need to stay with people and help. Dr. Chochinov yesterday in his testimony was very profound with several of the things he said. And one of the things was that we can always help with existential suffering and trying to alleviate and stand by people and not abandon them.
I would quickly add that I think advocating for your family member, like being that squeaky, noisy, annoying wheel. I always tell my patients, like, the squeaky wheel gets the grease, let's do this. And so for patients who are suffering, they need their communities, their family members to rally around them, to constantly call that specialist. I'm sorry, guys, but this is what I tell patients, right? Constantly call that specialist, be super polite, ask, try to move up. That doesn't solve the systemic problems in the system, but one, it shows your family member that you love them, that you think that they deserve that care. And actually, often I find advocating for them, with them, helps them get that care faster. Leonie just texted me that someone had their hand up. Did someone else want to answer that question? Go ahead, sorry.
Thank you. I might, okay. So for the specific question at hand, I believe I heard correctly or read correctly that this is a loving, supportive family who's concerned that their loved one is feeling the push towards MAID because of a really long wait list for mental health support. This is, we know, and again, for any care, systemic problems need systemic solutions. And for all the legislators and all of the heads of departments who have the capacity to permit these supports is to prioritize such things systemically. Now, as caregivers and family and loved ones, as Dr. Coelho, forgive me if did I say that correctly?
You can call me Ramona, but it's cool. Yeah, it's perfect.
Said advocacy is key. So like in my lived experience, and it may not necessarily be mental health supports, but everything, like since 2015, despite living in Toronto, I don't have access to clean, potable drinking water, right? That's a basic need, right? Or access to medications and pharmacare, etc. And became the face of what happens if the most vulnerable have the longest wait times or are denied. And it's advocacy that saved my life. The entire world who witnessed, and people who didn't even know me, and people who loved me, like you loved your loved ones, contacting every single MP they could, contacting every single source of support or person in power that they could. And even if you are not a member of a faith community, contacting every single faith community you can, because there are tithes or zakat or alms, etc., that are dedicated towards expediting these resources to you. And a lot of people don't know this. And where privileged autonomy can then become the most marginalized access, where it's not a hand up, but it's a source of access when we really, really fight for it. Yes, it's a squeaky wheel, but we have to also question systemically, what is it that is causing the wheel to constantly rust, right? So dismantling it from the root causes of systemic and structural violence, and what we as a society and in everyday life and as caregivers can do to really, really leave no one behind. What does it mean when we say nothing about us without us, to leave no one behind? That phrase itself comes from Black disabled people facing colonial violence, white supremacy, apartheid in South Africa, right? And it's been appropriated by governance that is refusing to dismantle disability poverty, that is refusing to allow for the supports we need to live. And so it becomes caremongering of everyone who loves and cares for this person and community to really leave no one behind. That's what I would say. So there are hidden resources that most everyone in existence has no idea exists, but really dismantling the systemic problems that are causing this to begin with is really important for people who hold that power. The other thing I would take, for example, some people use the case of my sister in many different health conditions, Sophie, who Dr. Herx mentioned, with chemical or environmental sensitivities. There are many people with similar, airborne fatal risks, whether it's MCS, mast cell disease, adverse reactions to fragrance. I'm using this as a case example. This was a preventable death where an entire community could have fixed it. Her floor, where she lived on in that building, her landlord, everyone in that building could have made a conscious decision to go fragrance-free to save her life. It takes a village, it takes a building, it takes a world, and we have to commit to leaving no one behind. Great.
Thank you.
Can I add something just for 1 minute? I know time is short, but one of the important concepts that I've been incorporating into my practice lately is something I've learned from a bioethicist called Carter Sneed, and he works at the University of Notre Dame. And he talks about what is needed for human flourishing. And he says that we are at our best when we are caring for another human being, and that we need to create practices and communities of uncalculated giving and graceful receiving. We're often good at helping other people, but we're not often good at accepting help ourselves. And I think this is something that we can all work on, is create these communities of, in palliative care, we have a movement called compassionate communities, which someday I would love to talk to you more about, but it is this sense of we are there, we take care of each other, and we give and we receive gracefully. And so that might be a good positive note for me to finish speaking on, but that is something we can do something about.
I think Catherine will lead us through now.
Yes, thank you again. It is our practice in the Disability Filibuster to spend a quiet moment of remembrance. And so I invite everyone now for a very brief moment to reflect upon the loss of life of someone that you know or know of who should be with us today, were it not for systemic injustice. Thank you, everyone. This is a space for coming together to speak about justice and to practice the teachings of justice. You have all made beautiful and lasting contributions today, each of our panelists, and I thank you. I thank our audience members and encourage you to return to the filibuster space. We will be broadcasting again on Sunday, 2 days from now, with a continuation of our conversation about medical ableism, featuring a very deep look into the experiences of people with intellectual disabilities and how they perceive the dangers of MAID expansion. I hope we'll have some of you with us then. Thank you all to everyone who has contributed behind the scenes, our interpreters, to Gabrielle for her extraordinary efforts to make this special edition a reality. We continue our work, and we'll see you again very soon.